Good afternoon, everybody, and that's an honor to be here. I know some faces here, and it's good to be here. This is an interesting topic that was given to me, and I'm sure that we are going to have a good discussion. So Dr. Simpson talked about the case, a 54 years old lady treated for AML in CR, but MRD positive. She has a fully matched donor, it's a sibling donor. Should we go ahead with transplant, or should we monitor the patient's MRD, give some chemo? That's a quite interesting question. So before I answer it, I will have to say, I'm honest with you, for MRD positive relapsed refractory AML in adults, no state-of-art therapy, to be honest with you, in 2019. It's different from ALL. Obviously, with ALL, if the patient is MRD positive, now you have an FDA-approved drug, which is blinatumomab. But AML is a different story. So no standard chemotherapy regimen. Obviously, the goal is achieving CR. MRD negative, I prefer to take a patient to transplant whose MRD is negative. But how we can incorporate new targeted therapies into the overall strategic plan. So can we use MRD as a way to obviously modify our treatment strategy in patients? Can we use it to risk-adjusted treatment as we do it, for example, in ALL patients? And how MRD status directs the decision who to transplant or not to transplant. Obviously, transplant is a big stick, isn't it? You know, the 100-day mortality is 5%. If a matched sibling transplant in the first 2 years, non-transplant related mortality is 10 to 15%. If it's a mod transplant, 2-year transplant related mortality is about 20 to 25%. So if we can't avoid transplant, that's, it would benefit the patient. Question number 3, can we distinguish early recovery from persistent AML? Or other question, can we predict early relapse by using MRD? Or how and when to convert MRD positive to MRD negative? Can we do that? So what is this minimal or measurable residual disease, or MRD? So this is obviously detection of the leukemic cells. When we talk about CR, we look under the microscope, or pathologists look under the microscope. If the blasts are less than 5%, when the absolute neutrophil count is above 1,000 and platelet count is above 100,000, we call it CR. But in MRD, obviously, we are using different techniques. We could use multicolor flow cytometry, and with a sensitivity 10 to the power of 3 to the power of 4, or we could use PCR, and the molecular CR is if the MRD is less than 0.01. For patients who are Philadelphia positive, that's a typo. The BCR-ABL1 ABL ratio should be less than 0.1. Here it says 0.15. That's a mistake. Should be 0.1. And how we could do detection of MRD by multicolor flow in AML. Obviously, you want to differentiate normal leukemic cells from abnormal myeloid cells. And there is a concept called leukemia-associated immunophenotype, but this is very different, actually. Common leukemia-associated immunophenotypes are probably less than 5%. And make it in a standard way is very difficult. There are aberrant lymphoid antigens such as CD19, CD7, CD56, aberrant levels of normally expressed antigens, and then early or later antigens. You need an expert to know the patterns of normal and regenerating and bone marrow, and then we should be able to compare MRD to the original phenotype at diagnosis. You need to have done this at diagnosis as well. And so this could be challenging. As I mentioned, the sensitivity is 10 to the power of -4, and it's available. However, it depends on the number of the cells, or they call it events. It's from an equipment point of view, is intensive. It needs, as I mentioned, an expert. So many centers send it to central labs. It hasn't been a standard yet. And the antigen expression might change post-chemotherapy. So it might, when patients relapse, you might find new actually antigens. And I would say this technique is applicable to about 80% of patients with AML. This is a study from Germany, and they look at the log difference after induction. These patients were in complete remission. And they look at the MRD by flow cytometry, and interestingly, patients whose log difference was more than 25%, they had a better relapse-free survival, but the overall survival didn't matter. The same study, they look at MRD by flow after consolidation, and patients who had more than 25% log difference, both they had better relapse-free survival and overall survival. You could use PCR. There are certain leukemic fusion transcripts, such as translocation 1517 in APL, translocation 1821, or inversion 16. Obviously, this is applicable to about, I would say, 25 to 30% cases of AML, and it's sensitive. However, it's not widely available. As I mentioned, since it's limited, you can't use it for everybody. It's about in 25 to 30%. And it still needs some type of standardization in the method. You could do mutation detection, such as NPM1, FLT3, MLL, KIT, and DMN3A. As you know, NPM1 is seen in about 30% of patients with AML, and not actually 50% of patients who have AML and they have normal karyotype. And there is some data that detecting NPM1 after induction can actually have prognostic value in whom is going to relapse. This is a study from France, and they monitored the patients' NPM1 after induction, and those who had at least more than 4 log reduction in the NPM1 after induction, those patients did much better. They did this on peripheral blood and bone marrow, and this was right before taking the patients to a stem cell transplant. You could look at this is again looking at the MRD in patients with core binding factors, which are considered good risk AML, and again patients who were positive for MRD long term, they had more risk for relapse. So they divided patients to 2 groups. One group, the level of MRD was less than 1%. The probability of relapse was lower in those patients. Checking for PML-RAR alpha in APL patients, these days we are doing it more frequently. You could do it on peripheral blood, and there is actually good data that patients who become MRD negative after induction, they do much better later on. And I would say in all comers APL, about 5 to 10% of them could relapse. If it's high-risk APL, about 10 to 15%, they could relapse long-term. So checking MRD by PCR, looking at the PML-RA alpha on pre-fraud is a good way to monitor these patients. The question is that how frequent we should do that. It hasn't been, again, standardized yet. There is data about using next generation sequencing in patients. The sensitivity is 10 to the power of minus 6, 10 to the power of minus 7. It's very sensitive and specific, and you could use either on fresh or frozen samples. It's relatively standardized. It's very expensive and not widely available. You need to have a central lab. And this is looking at MRD by NGS in patients who receive induction chemotherapy. They were in complete remission. And there are certain mutations that are, when we get older, we develop clonal hematopoiesis, and sometimes they actually could make the picture a bit muddy, so we should be able to differentiate those mutations. Talking about MRD, and our colleague from Colorado mentioned about the newly approved FLT3 inhibitors. We know that there is some data about using maintenance. This is from a retrospective study. Patients who were put on sorafenib, they were started around day 60 to day 100 after Allo, and they were given sorafenib. And as you see, patients who were given sorafenib maintenance had a significantly higher overall survival at 2 years and progression-free survival. I have to add that sorafenib is not FDA approved for maintenance, but it has anti-FLT3 effects. And this was a retrospective study, and interestingly, these patients did not have increased incidence of graft versus host disease. There were some anecdotal data that if you put patients on sorafenib post-transplant, you could increase the risk of graft versus host disease. This was a SORAMIN trial. It was a prospective study that they used sorafenib post-Allo for patients with AML who were FLT3 ITD positive. The previous study, which I thought this was again for FLT3 ITD, not TKD. As you know, the majority of patients who are FLT3 positive are FLT3 ITD. This was a prospective study. Unfortunately, it was closed early because they couldn't enroll many patients. But it was randomized, double-blind, placebo-controlled, controlled multi-center study, and 2 years relapse-free survival for sorafenib was 85%, and for the placebo group was about 53.2%. So as you see, more than 31% difference in relapse-free survival. So patients, I think that's something that we need to pay attention. As I mentioned, sorafenib is not FDA approved for AML and for maintenance post-transplant. There is interesting data about using low-dose azacitidine post-transplant patients. And this is, again, it's not FDA approved. However, there is data that if you use azacitidine, somehow it modulates the donor T cells, and the number of CD8 positive T cells go up in these patients, and it improves, as you see, patients who had increased CD8 positive cells, they had a better relapse-free survival. And interestingly, it somehow has some modulatory effect on patients, and you would get GVL without GVHD. This is another study that used low-dose azacitidine for patients with AML and MDS. When I say low-dose azacitidine, it's about around 35 milligram per meter square, starting between day 40, 45 to day 60. It's obviously not FDA approved, but people have started using this for patients who are high risk, or if they are MRD positive right before transplant, they think that this might be a good strategy. And it, as you see here, it improves not only event-free survival, but also overall survival. The issue is that why we use low-dose azacitidine here. As you know, post-transplant patients have a lousy hematopoiesis. So if you want to give them chemotherapy, it could drop the counts. There is a risk for example, them losing the graft. So you should be very careful to how much chemotherapy you could administer to these patients. They are very sensitive. And obviously, they are very immunocompromised with administering chemotherapy. You increase the risk of infection in these patients. So what treatment would you choose for this patient with an Allo HSCT intent? To be honest with you, you could say no treatment, just go ahead with transplant. You could say go ahead with transplant, but use hypomethylating agents, low-dose azacitidine. If you give more conventional chemotherapy, single agent or combination, I am not sure, to be honest with you. Why I'm not sure? Because when you give chemo, basically, you increase the risk of infection, chemotherapy-related side effects, and you could worsen the patient's performance status. And if, as you know, when you want to take a patient to transplant is the best way to describe transplant is like to be in a roller coaster. And as I mentioned, it's a big stick. And for transplant, you cherry pick your patients. So if you give more chemotherapy for a patient who is MRD positive, I don't think so that's a good idea. I have to see what the panel would say, but I am not in that camp. What about using newer agents that were discussed if a patient is MRD positive? These newer agents, if you go by the FDA approved indications, they are for relapsed refractory. They are not for MRD positive patients. So, how long you should keep these patients on this newly approved drug? There is no data. And if you wait, as I mentioned, patients could develop side effects. The donors might not be available. So you could mess up the transplant plan. What about using gemtuzumab? So it's obviously, I think this is using I don't think that's a good idea. One, obviously, is too much for a patient who is MRD positive. The other issue is that this drug is associated with increased risk for veno-occlusive disease or VOD. And if you are thinking about transplant, it's better to shy away from this drug. Clinical trial, I don't think you would find a clinical trial for a patient who is MRD positive. So that's most clinical trials are looking for patients who have a measurable disease, BLAST at least 5% or higher. So my take would be that I would take the patient to transplant. I would repeat the bone marrow around day 40 to day 60, check chimerism and MRD, and I would use low-dose azacitidine for after getting authorization from the insurance, obviously, and checking the patient's count on a regular basis for at least 4 cycles and follow the patient. That would be my take.
All right, thank you.
Thank you.